Good morning, everyone. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. Per usual, we'll get started with some announcements and logistics, and then introductions for today. Next week, please take an extra moment to find some gratitude. We are taking next Tuesday off as part of Thanksgiving week, so catch your breath, and then be sure to come back on Tuesday, December 2nd, when we'll be hearing Hematology Mythbusters, given by Dr. Tom DeLowry from OHSU. As many of you know, Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Centers. I'm here live in Southern Auditorium at Providence St. Vincent, and typically Grand Rounds is live here in the room at 8 a.m. on Tuesdays. Grand Rounds is also sometimes live at noon on Tuesdays at Providence Portland. You can earn CME credit by being live in the room, watching live virtual on Teams, or by watching a recording of the event. If you look at your Grand Rounds invite each week, that will let you know where and when we're meeting, and also has the link to the recording. I'll be monitoring the Q&A throughout today's session, so for those of you watching online, please feel free to post any comments or any questions, and I'll mostly hold those until the end as time permits. And now introductions for today's very special talk. I am delighted to introduce the 2025 Dr. Jeffrey Clevin Lectureship, which was established in 2018 and seeks to bring an exceptional educational program with particular emphasis on lifelong learning and high-value care. Dr. Jeff Clavin joined the Portland Clinic in 1977 and in 1994 was named the Chief Medical Officer. During his time there, he was instrumental in the clinic's focus on the triple aim of access, cost effectiveness, and high quality care. And this lectureship honors the long-standing relationship between Providence and the Portland Clinic for their great clinicians and leaders. Dr. Clavin's attendance to this day, now virtual on the Teams Live platform to weekly Grand Rounds, is just one testament to his dedication to lifelong learning, as well as his commitment to excellence in care of all of our patients. So hello and thank you, Dr. Clavin. Our speaker today is Dr. Renata Thronson, a clinical associate professor of medicine at the University of Washington and a teaching physician at the Adult Medicine Clinic at Harborview Medical Center in Seattle. Dr. Thronson also serves as the clinical editor of assessment and education programs of the American College of Physicians. She earned her undergraduate degree from Reed College, went on to do medical school at Harvard, and then her residency at University of Washington, followed by a fellowship in medical education. Dr. Thronson is a primary care physician practicing in the Adult Medicine Clinic at Harborview Medical Center, with a clinical focus in longitudinal general internal medicine, specifically serving patients at risk for health inequities. She's also a dedicated clinician educator with particular interest in the development of trainees and junior faculty as educators and leaders, and also primary care training and retention. Thank you, Dr. Thronson, for joining us today.
Hello. Thanks, everyone. Is the audio all okay? Thumbs up. Hi, residents. I was told you'd be in the back. I might bring you to the front later, but not quite yet. Thank you all for having me here today. This is great. I am here to talk with you about every primary care physician's and every internist's favorite topic, which is dizziness. And I know for sure that this is your favorite topic. And I know that it doesn't give you any sort of sense of dread whatsoever when you encounter a patient who is dizzy, especially in clinic when you're running 20 minutes behind. But actually, I hope to teach you to love dizziness a little bit more today. I think that as general internists, dizziness is the quintessential topic for us, right? We can't send an undifferentiated dizzy patient to a cardiologist or a neurologist or an ENT doctor or a psychiatrist. That person always needs to start with us. And there are many things that we can do to help our dizzy patients, and there are many things that we need to do to identify dangerous causes of dizziness right away. Sadly for me and my children's college funds, I have no financial disclosures. So anyway, you're getting an unbiased lecture from an academic doctor. These are the questions that I hope to answer today. And we're going to spend the most time on the first 4 because these are the scariest for internists. So first, our initial approach, which can feel overwhelming. Second, the diagnosis and treatment of BPPV. Third, the best approach to a patient who has vertigo and you swear they have BPPV, but they do not have a positive Dix-Hallpike maneuver. Fourth, what red flags on history or exam should prompt neuroimaging or other workup and/or referral. And then finally, I'll spend a little bit of time talking about disequilibrium and nonspecific dizziness. So first, a general approach to the differential diagnosis of dizziness. Many of you have seen the differential diagnosis for dizziness grouped into these buckets before, and I'll review them briefly here. Qualitative descriptors of dizziness can help us narrow our differential diagnosis if we listen for really specific features. So for pre-syncope, we're listening for our patients to tell us that they need to lie down or sit down in order to forestall that sensation of dizziness. If our patient has vertigo, they may tell us that they have a sensation that they are moving or that the room is moving. It doesn't necessarily have to be spinning, but vertigo is by definition a hallucination of motion. And then disequilibrium, which is the kind of dizziness that's least likely to be described as dizziness by our patients, is really characterized by an imbalance, which is prominent or exclusively present when a patient is upright or walking, trying to maintain their balance. However, it can be very difficult for some patients to describe the subjective sensation of dizziness. And it can be difficult for us to elicit the type of dizziness just based on those qualitative descriptors. So I highly recommend using a second highly useful approach to the myriad illness scripts for conditions that cause dizziness. And that is to focus on the timing of the dizziness and the triggers. A brief aside for the budding medical educators among you, an illness script, which you may or may not know, is a description of a typical disease entity, including patient characteristics, symptoms, chronology, timing, severity, and relevant positives and negatives. So it's like a template for a disease or condition. And our patients do not generally follow these scripts exactly, but you do want to think of an illness script as a general blueprint for any particular kind of diagnosis that you're considering. So we can narrow our differential diagnoses by focusing on the timing and triggers. Once we've tried to put someone into a bucket, maybe they fit, maybe they don't, we're going to apply this additional cognitive and tool to narrow down our patient's dizziness to fit into a smaller number of illness scripts so that we can compare and contrast and figure out what's going on. So this is a framework that was laid out in a 2015 paper, and it's the first one in my references, if you are interested, which proposed grouping dizziness into 4 different categories. It's actually more of a 2x2 table. So dizziness can be thought of as episodic, meaning it comes and it stops, or continuous, meaning it comes on and persists, or triggered, meaning something provokes it, or spontaneous, meaning that it comes out of the blue. So once we've narrowed down our differential based on this history, you can then compare and contrast our patient's story with a smaller number of illness scripts. If you're in the episodic positional dizziness box, you don't have to think of the entire differential diagnosis for dizziness anymore. You just have to think of a few things, really only one of which, or 2 of which, is can't miss, okay? Because always the first concern is not missing a devastating neurologic or cardiac cause in which timely intervention could save our patient or preserve their health. I'm going to come back to this table over and over again during this talk. But for example, in the setting of continuous dizziness, okay, dizziness that comes on and doesn't go away for a while, if this continuous dizziness was provoked or preceded by trauma, for example, or sustained heavy alcohol use, we have a couple of can't miss things that we must think about. For example, the presence of trauma in a patient with this illness script, continuous dizziness, should prompt us to consider neuroimaging because maybe they have a basilar skull fracture, okay, or a cerebral hemorrhage. If this patient with continuous dizziness has had prolonged and heavy exposure to alcohol, then we need to be considering Wernicke's encephalopathy. And I'm going to return to this table periodically to highlight the red flags, again, which you should be thinking about based on which illness script your patient is following. Okay, the bulk of this presentation in the middle, we are going to be talking about vertigo. And we're going to be talking about the specific scenario of episodic positional dizziness, which, much as we would like to think otherwise, has a differential beyond BPPV. Okay, so there are some things on this list that I'm not going to spend time on. Orthostatic hypotension is pretty easy for internists. It is not nearly as scary as vertigo, so we're not going to talk about this here. Okay, I think you all can recognize orthostatic hypotension, know how to diagnose it, and understand the differential diagnosis. Less commonly, episodic triggered vertigo could be caused by rotational vertebral artery syndrome, which you probably don't know much about, but I'm going to tell you, you don't have to worry too much about that, okay? Because what it is extrinsic compression of a vertebral artery provoked by head turning, usually in the setting of like lots of osteophytes or osteoarthritis in the neck. And you know the treatment for this? You just don't turn your head that way. So even though this is not a common, comfortable diagnosis for internists, it's not an urgent diagnosis to make, okay? So when we are in this bucket of episodic, positional, or triggered vertigo, the thing that we need to distinguish from our benign cause, BPPV, is a non-benign cause, central positional vertigo, which can be caused by cerebellar or brainstem lesions, okay? MS, tumors, stroke. So let's take a case example. This is a patient you have probably seen in clinic before, and if you haven't, you surely will. He's a 54-year-old man. He describes a sensation of spinning when he tilts his head to put in his eye drops or when he rolls over in bed. This has been ongoing for a couple of weeks, and it resolves after about 30 seconds. He has hypertension, and on exam, he is indeed hypertensive, and he has a totally normal exam. You do the Dix-Hallpike maneuver, and he gets the dizziness, but there is no nystagmus that you can perceive. I am sure that many of the more experienced physicians in this room have had this exact thing happen to them, and many of the less experienced people may have as well. If you haven't, you will. So if you're taking the boards, these are your options. We'll get back to this slide because what you're really thinking is one of these three things. I'm going to let you all read through this, and I'm not going to ask you to disclose your answers, okay? But I want you to admit to yourself what you're thinking. Okay? Everyone's got their answer in their mind? Okay. No one is a bad doctor in here, because if you're thinking, number one, it's probably not BPPV, I got to look for something else, that means you're a super careful doctor. And you are right, because this guy, you are partly right, because this guy, although he has a really high pretest probability for BPPV, also has cerebrovascular risk factors, which makes us really want to be confident in our diagnosis of a benign cause. Okay? As an aside, I personally still think this guy has BPPV. We'll get to that in a second. Okay. If you chose number two, you are not alone. And in fact, you do not have to admit this, but sometimes you probably even skip the Dix-Hallpike maneuver. But don't do that. Just feel that you are not alone. Okay, this quote right here is actually from quite a colorful read, which somehow was actually published after peer review, despite its rather snarky tone. But it's in my references if you'd like to read it. I thought it captured really well a sense that doctors feel when you know this patient has BPPV and they just won't give you the nystagmus. Okay. So if you chose number three, you may be too humble a doctor, okay? Because you can do everything right and still get no nystagmus. And that's for two reasons. Dix-Hallpike is not completely sensitive. First of all, because it is meant to detect posterior canal disease only, which is 80% or so of BPPV, but 20% of the time it might not be. It could be BPPV in another canal. And also the nystagmus can be really subtle. That's why the neuro-otologists have those special like glasses and cameras that they can use to quantitate the nystagmus, but we don't have those things in clinic, okay? I promise, give you some tips and tricks for increasing the yield of your Dix-Hallpike in clinic, but first let's dive in to how to do it. One way that I learned how to do the Dix-Hallpike maneuver and really made it stick was by picturing how the semicircular canals are oriented within your inner ear. So take the posterior canal. It is oriented 45 degrees. So it's in the coronal plane, it's up and down, but it's tilted 45 degrees posteriorly, okay? So this is why we have our patient, when we think they have posterior canal disease, turn their head 45 degrees to the side, because that brings that canal into the plane of rotation when we're tipping their head back to do the Dix-Hallpike maneuver. And I promise to demonstrate this later. So that's why we ask our patient to tilt their head to the side, because it brings that canal exactly into the plane of rotation, maximal movement of the otoliths inside the canal when we do that. 5 to 15% of BPPV is in the lateral, or is in the lateral or the horizontal canal, which is actually even way easier. It's just oriented like this. It's perpendicular to the ground when your patient is in the supine position. So to diagnose this is so much easier than Dix-Hallpike. You just roll them over like a log and you watch for the nystagmus. Yes, there is 5 or 10 or 15% of cases are anterior canal BPPV. I'm not going to talk about that, because if we can do 85 to 90% of BPPV in clinic, that is better, I think, than most docs are doing. And if it takes a vestibular PT to diagnose the remaining 5 or 10% of anterior canal BPPV, I am not going to feel upset about that. Okay, so let's focus on knowing the Dix-Hallpike primarily, but then you could add the log roll test, which is pretty easy. Okay. So when we're having a great day in clinic and this nystagmus is present, you're not done. To confirm BPPV, the nystagmus has to rotate in the right direction. It has to come on after a short latency period, and it has to go away. Otherwise, it might not be BPPV. So the nystagmus of BPPV is, if you want to say a fancy word on rounds to anybody, is georotatory. It goes towards the ground, towards gravity. It comes on after a short latent period of a few seconds. So you do the Dix-Hallpike, the person does not immediately become vertiginous or exhibit nystagmus. They take a couple seconds, and that latency period itself shortens with repeated testing, and I'll explain why in a second. First, I'll point out that the latency period is something you can pick up on history too, although you'll really have to ask about it specifically. So when a patient confirms that their episodic positional vertigo comes on a few seconds after they turn their head, this is highly reassuring for BPPV, but you might not be able to get that degree of detail from your patients. The reason for this is that otoliths are mechanical. They move way more slowly than your nervous system does. So the latency, so you move your head and the otoliths move, there's a little bit of a lag time because there's something mechanical going on. Latency present on history and revealed on exam tells us that it's a mechanical problem, not a primarily neurologic problem, okay? Neurons are quick. There's no latency. Otoliths are a little slow. There's a little bit of latency. Okay, quick aside here. All vertigo is worse with movement. You could have a cerebellar stroke and it's worse when you're moving. It's better when you're still. So if vertigo only improves when you're still, but doesn't extinguish completely, you're not in the right illness script for positional or paroxysmal vertigo, okay? So don't confuse it's better when I'm still to it's gone when I'm still. some tips for increasing the yield of the Dix-Hallpike. Because remember, in our 54-year-old man with risk factors, we really want to see that nystagmus to feel secure sending him out of clinic that day. So anecdotal tips by me are avoid asking for gaze fixation. So we frequently will ask our patients to stare directly at us so we can see the nystagmus, but gaze fixation actually suppresses peripheral causes of vertigo, so don't do that. Generally what I do is I just ask my patients to try to keep their eyes open and give them no further instruction than that. Also, it can be easier to see subtle torsional nystagmus if you're looking at a little blood vessel out in the periphery. Because as you can imagine, that little blood vessel, it's easier to see that ticking up and down subtly than it is to see the pupil or the iris actually moving. As an aside, I've also had good luck seeing nystagmus even with a patient's eyes are closed, because you can actually kind of see the twitching of the eyeball underneath their eyelids. Okay, and here's where we get to give due homage to Dr. Epley, who I'm told is an Oregon native and trained and worked here. He had this idea of this thing called statoconia. Okay, it's the idea that otoliths are a bit stubborn and they take some convincing to move about. So the good Dr. Epley himself employed an 80 hertz bone vibrator on the ipsilateral skull to try to wiggle those otoliths around and make them more mobile. But I don't have one of those. I don't know if any of you do. Sounds kind of scary. But repeating the maneuver actually also gets them moving a little bit. So if your first Dix-Hallpike is negative, have your patient sit up and do it again. It might be positive. And actually, you have to do it twice anyway, because you're looking for that decrease in latency period as you go along. There's also actual evidence, not just anecdote, that head shaking increases the yield of Dix-Hallpike by about 15%. Now, this is not a huge increase in yield, but it's super easy to do, because from the head hanging position in Dix-Hallpike, imagine the head's off the edge of the exam table. You just have your patient rotate their head, or you do it for them, about 5 times, 30 degrees side to side. It does not have to be fast or violent. In fact, I recommend highly against any sort of quickness or violence in any of these maneuvers. And you will get an increase in your Dix-Hallpike. So these are our options if you don't have the 80 hertz bone vibrator. Okay, you can remember all my anecdotal tips. You can do head shaking, you can repeat the maneuver, and the test can still be negative. You're not a bad doctor and you're not doing it wrong. The diagnosis can still be BPPV. And evidence shows that in these patients with a high clinical likelihood of BPPV, even with negative naked eye nystagmus, most of these people do respond to the Epley maneuver or canalith repositioning. So this is actually pretty helpful, because failure to respond to Epley repositioning can itself be a diagnostic clue that you need to go further in your workup, right? So knowing how to treat BPPV in your office, often with a single visit, will both help you diagnostically and, as I've said before, it is one of the very few things that you can do as a primary care doctor that will fix someone right away and dramatically. And so we should all be able to do this. It comes in really handy. And it's worth knowing the maneuver really well for posterior canal disease. We will go back and I will show you a way to do the Dix-Hallpike that you will not forget later, as long as we have time. So I'm going to talk a little faster so we can do that. Okay, so let's get back to our case. And I'm going to reframe it for you as a 54-year-old man with probable BPPV, but a negative exam, and he does have vascular risk factors. So which of the following is going to be your next step? And again, I'll have you guys think about what your answer is, and I will not ask you to disclose what you're thinking. We want to be confident in our office-based diagnosis here because of his risk factors. So these are my answers. First, because of his age and uncontrolled hypertension, it increases our concern for cerebrovascular disease. So I'm going to try to increase my confidence in his exam. I'm going to add the head shaking. And if that doesn't work, I'm going to do the supine roll test in clinic. One isn't better than the other, but you know, you've got 20 minutes. Now, obviously, this visit has already lasted 30, so I acknowledge that, but we got to do what we got to do. I would do head shaking first because it's so easy to tag on to the Dix Hallpike. You're already there. If that fails, you could do the log roll with him. But let's say that you do these things and it's still negative. Remember, I told you it could still be BPPV. So you got to use your judgment here. But in this patient, it would be totally reasonable to try repositioning him with careful follow-up. This has been going on for 1 to 2 weeks, so we're dealing with a kind of like, that's the timeline that we're dealing with. It didn't just come on yesterday. We're not missing something hyper acute. You could reposition this guy and call him in 1 or 2 days. And if he is better, that is very helpful for you diagnostically. In fact, you've solved your problem. If he's not better, you need to neuroimage this guy because he might be having a central lesion, or he might be having a central lesion if he's truly having positional dizziness, okay? And then there's this other thing. If I weren't so absolutely sure that this dizziness was triggered by position, say I don't have 100% confidence in the history that I took. If I'm not 100% sure that that dizziness is provoked by position and only by position, remember I told you that all vertigo is worse with movement. So if I've got a vaguer history there, then I need to be more concerned about something that's not mechanical. Like I need to be concerned about paroxysmal dizziness in this guy. I need to think about TIAs, okay? So as promised, we're back to this framework, reviewing our differential for just this episodic positional vertigo. So to review, the alarm features that make us think of a central cause for triggered vertigo or central positional vertigo are absent latency period on the Dix-Hallpike. Remember, there's latency because the otoliths are mechanical. If it's rapid, then it might be a neurological problem. And if the nystagmus is sustained or atypical, that also suggests a central problem. Otoliths should stop moving eventually. So if the nystagmus and dizziness keeps going on for longer than a minute, then you need to be concerned that this isn't actually a true Dix-Hallpike, a true positive Dix-Hallpike. Yeah, that's okay. Yeah, totally. Yes, because, yes, sorry, the question was, do you always do the Dix-Hallpike on both sides? My answer is, I'm a busy primary care doctor, so I take my best guess as to which side it's going to be first. If my patient says, I'm always going for the cereal box on the right side in my pantry, and that's what triggers it, or if they can even tell you it happens when I'm checking my blind spot over to my left side, then I will go for the side I think it is, but I'll always repeat it on the other side. And in fact, I usually do my high suspect side, then repeat on the other side, because I figure that's moving those otoliths around too. And then repeat on my first side again. And then I've built in my repeated maneuvers and shaken up those otoliths a little bit. Sure. But if it's positive on your first try, you're all done. Okay. So remember that I mentioned that if our 54-year-old spontaneous dizziness were not clearly triggered by the head turning, I've emphasized this over and over again, all dizziness is worse when you move your head. But if it's not absolutely 100% triggered by moving your head, then you need to consider yourself to be in the category of episodic and spontaneous vertigo. So easy to confuse periodic and triggered from periodic and spontaneous, okay? And the differential diagnosis for spontaneous vertigo, which doesn't last, includes things like posterior circ TIAs and cardiac arrhythmias. There are a couple of other confounding diagnoses in the illness script for for episodic spontaneous vertigo. And these include vestibular migraines and Meniere's. But the illness script for those clinical entities are really sufficiently different than a TIA or an arrhythmia that you should be able to distinguish those on history most of the time. So dizziness that is rapid onset and offset, particularly if it is short-lived, is more alarming to me than symptoms that build up gradually or persist on the timeline of something like Meniere's or a vestibular migraine. Okay, so we've got these things in this episodic spontaneous box, and it's really about listening for the right illness script in here. And when I have episodic and spontaneous and it's quick on, quick off, and it's not provoked by position, then I'm worried. We've got cardiac arrhythmia, maybe giving them some hypoperfusion, or we've got TIAs, high on our differential. Okay, let's move down into the force box, which is the final category of dizziness on this table, which is continuous vertigo that is spontaneous in nature. So say our same 54-year-old patient with hypertension presented not with paroxysmal vertigo, but instead with sudden sustained dizziness. We're not even going to do Dix-Hallpike in him, okay? Because it's not the right clinical scenario. It's not the right illness script. This guy is vertiginous in front of us. It's not going away. We already know it's not BPPV. We're not doing those maneuvers. So but there is basically a single benign cause of spontaneous continuous vertigo, and that is vestibular neuronitis, which is essentially like Bell's palsy of the 8th cranial nerve, right? It's just sudden dysfunction of the 8th nerve, idiopathic/viral, who knows? It's totally benign, it's self-limited. But how do you distinguish that from a central cause, which is a stroke or a hemorrhage? Okay, first of all, general neuro exam. I'm going to talk to you about some findings that should make you suspect central versus peripheral causes. Central is in the brainstem or the lateral medulla, which is where the 8th nerve nucleus lives. Peripheral vertigo is in the semicircular canals or in the prenuclear 8th nerve, okay? So the 8th nerve before it gets to the brainstem, if that's the problem, that's vestibular neuronitis. If it is the 8th nerve in the brainstem, or if it is the cerebellum causing you problems, that's central vertigo. So some things that should always suggest central vertigo for you. This is, you send this patient to the ER from clinic. Severe impairment of gait. People can feel a little dizzy with peripheral vertigo. They can have a little bit of trouble with balance, but they should not be falling all over the place. That should make you worried for central cause. Ataxia of the trunk. So someone is sitting and swaying while you're examining them. That is central. Basically, if you can tell that someone is impaired the minute you walk in the room, you should not be assuming that that is a benign cause of vertigo, okay? And then we're going to look for signs and symptoms of other things that are going on in the general neurologic neighborhood of the cerebellum or the 8th nerve nucleus. And I credit Dr. Marty Samuels, who is a late great physician neurologist, who I got to hear talk a few times and from whom I learned this concept of the neurologic neighborhood. It means when you're considering a central neurologic problem, think about what else is in that area, because it's very unlikely that you are going to get a tiny stroke that only hits your 8th nerve nucleus, right? You're probably going to get some impact on the surrounding structures, which in the case of the lateral medulla are other lower cranial nerves, the long tracts, and then you can also get a Horner syndrome from impairment in the lateral medulla. You don't have to remember all of these things. That's called Wallenberg syndrome, which some of you may remember from way back when. But you do need to know, okay, I'm going to do my cranial nerve exam and I'm going to do the rest of my neurologic exam. And if I find other signs that are attributable to the brainstem, then I'm worried. Cerebellar signs, now some cerebellar strokes present as isolated vertigo. There are a few, but most cerebellar strokes will also give you some other cerebellar signs such as hypotonia or discoordination. So we're going to do our good cerebellar and brainstem general neuro exam, okay? And then beyond the basic neurologic exam, when we're dealing with vertigo, the oculomotor testing is really important. There are some alarm features. There are some features of the oculomotor exam that we as internists feel pretty comfortable with, and I'll start there. So nystagmus. We know how to look for nystagmus. We basically just look at people's eyeballs. Sometimes we have them move their eyeballs around and see what happens. But nystagmus that goes up and down, if you see that, so if you have someone look up and they're beating upwards or look down and they're beating downwards, or they're doing that spontaneously, that is always central. Nystagmus from the peripheral nervous system or nystagmus from the vestibular system should never go up and down. Also, nystagmus from the vestibular system should never change directions. So if you have someone gaze to the right and they have rightward beating nystagmus, and then you have them gaze to the left and it changes directions, that is also always central. Okay. So, and then finally, nystagmus that is rotatory or torsional, that comes on spontaneously, not with position or with change in gaze, that is also always central. So we're going to look for nystagmus, and if we see any of these central findings, then we're worried. I don't care how good a story it is for BPPV. Okay. Vertical skew is also a pretty easy thing for us to look at. Basically, that means the gaze of one eye is a little higher than the gaze of the other eye. And we can pick this up in clinic by doing the cover, uncover test. Have someone look at your nose, cover one eye, then move your hand and cover the other eye. And if they have to correct, if you see a little corrective saccade to bring that gaze back into alignment, then that means they have skew deviation. And that is always abnormal. Vertical skew deviation is always abnormal. Basically, anything uppy downy in the eyes when you've got a dizzy patient is really scary. Okay. And then finally, the thing that I think is hardest to do in clinic is this vestibular ocular reflex. And I think I'm not going to spend a ton of time on that because it can be pretty hard to master in clinic. But if you're feeling comfortable with it, I will tell you that an unimpaired vestibular ocular reflex in the right setting might make you worried. The reason being that unilateral dysfunction of the vestibular system is expected in vestibular neuritis, okay? If you have a perfectly functional vestibular system in your patient with persistent vertiginous syndrome, you must consider CNS causes, particularly if the vertigo is severe. This is a brief slide about the vestibulo-ocular reflex, which I think I'm not going to spend a lot of time describing right here, but basically is a test for loss of gaze fixation with head turning. So when it's impaired, the person cannot keep their gaze fixed. Now, this is really hard to see in clinic, and it's pretty hard to do in clinic. The good news is that a positive vestibular ocular reflex in the right clinical setting is actually reassuring for peripheral causes. I think if you're not really, really comfortable with this part of the exam, it is okay to not feel very comfortable with it. I think it's just very hard. And many ER doctors and neurologists have a hard time with this as well, which is kind of a limitation to our bedside oculomotor findings when trying to distinguish central from peripheral continuous vertigo. And that is okay, because it is okay to come upon things which we find difficult and don't feel totally confident about in our clinics, okay? I was very stressed about this. How do we tell central from vertigo, central from peripheral based on an oculomotor exam in clinic when I don't have all of the tools I need? And my friend Sean Evans, who is a neurologist at UCSD and very smart, he told me, Renata, if it's a good story for a benign cause and the exam is normal and you understand your exam, then that is good. If it's not a great story for a benign cause, and if the exam is either abnormal or you don't understand the exam or you're not comfortable enough to do it, then you need to get help. And that is okay. If you are not absolutely convinced that someone has a benign cause of vertigo in your clinic, you can ask for help. You get neuroimaging or you get a neurologist to help you. I think this applies to everything in medicine, really. Like, we're all good at certain things. Like, I actually feel really good at dizziness, but I need to get more help with endocrinology a lot of the times. And that's okay. This allows for us to understand our limits. All right? Okay. That aside, finished now. This slide now summarizes the red flags in continuous spontaneous dizziness. So, cerebrovascular risk factors and cerebellar, brainstem, or central oculomotor findings make us worried about our patient. This is the patient who is sitting in front of us who said, I had sudden dizziness come on and I am still dizzy. So the overall approach here is to nail down the timing and the spontaneity, take the likelihood of a central cause into careful account, then add your meticulous history and a focused neurologic exam to all that, including attention to neuroocular findings, to help you decide as the clinician the likelihood of a central versus a peripheral cause. We have now covered the first 4 questions. I will move on to the second 2 briefly, and then we can revisit Dix-Hallpike if we have time, after I answer any questions that come in on Teams and from the audience. So we're moving on from vertigo. Take a deep breath. It's done for now. We're going to go to things that are a little less stressful, but not necessarily easier in clinic. So the workup and treatment for disequilibrium and the evaluation of non-specific dizziness can be a little less satisfying than some of these other things, but they're very common presentations to us in clinic or in the hospital. So these 2 forms of dizziness have their own illness scripts. Disequilibrium, as I mentioned before, it's the least likely cause of dizziness to be described as dizziness per se, but it is always included in talks on dizziness, so I couldn't leave it out here because someone would ask me about it. Disequilibrium is really a sense of imbalance. It's prominent when you're walking, and it is prominent in older patients with multimorbidities, and we will talk about why in a second. And then non-specific dizziness, which is basically the cop-out, you can't figure out what other kind of dizziness this is, but also represents about 1/4 of dizziness in all primary care clinics, is non-specific. This tends to be the pearls for identifying non-specific dizziness is it tends to be untriggered, and the timing of it tends to build up over minutes rather than sudden onset. So those are 2 clues that you might be in a non-specific category. So let's take disequilibrium. We're going to review a typical illness script for disequilibrium in this 92-year-old woman with unsteadiness who was my patient. So you can see here that there are many reasons for this patient to experience imbalance, which occurs exclusively while she's walking. It's worse in the dark, improves when she's holding on to something, and improves when she's not trying to maintain her balance. The onset of this is gradual, months to years. It's not sudden. Her medical problems are diabetes, hypertension, and osteoarthritis. And on exam, she's not orthostatic, cardiovascular is normal. And then she has a lot of findings that could contribute to imbalance, and they're consistent with her morbidities, okay? Arthritis, peripheral neuropathy, decreased core strength. So you'll often see disequilibrium grouped like this into intrinsic and extrinsic causes. If you've been to a talk on falls or frailty or disequilibrium in older adults, you'll have seen this. You can think about disequilibrium this way as due to things that are intrinsic to the patient over here on the left side, or things that are extrinsic, iatrogenic, or environmental. But I also like to think about disequilibrium as a failure of one or more of the systems that we use to keep our balance. So the left-hand flow sheet is a vast simplification of what it takes to keep our balance. So there's multiple sensory inputs, visual, proprioception, then that all goes to our cerebellum for central processing. Then the cerebellum talks to our brainstem and even to our musculoskeletal system. And there are redundancies in this system, but the bulk of these processes and structures do need to be in good working order in order for us to maintain equilibrium. Remember Dr. Romberg, he studied patients with tabes dorsalis of syphilis. So his Romberg test is a test for peripheral neuropathy. What he proposed is that you need your vision, vestibular system, and your proprioception to be working to stand up. He had all of these young people with neurosyphilis who had intact vision, intact vestibular systems, but didn't have proprioception. So when they were standing up and they were using their vision and their vestibular system, they were fine. Suddenly, he has you close your eyes and you've got 2 hits against you now. You can't really rely on just one of these systems to maintain your posture and balance. So there are redundancies in here. And so for most younger people and healthier people without a lot of multimorbidities, disequilibrium is not typically a problem. This is why it is generally considered to be a multi-system disease. seen more often in elderly people and or a frail patient with a lot of organ disease. Okay, so our 92-year-old woman who is unsteady, these are our options. We can do neuroimaging, we can stress her, we can send her to physical therapy, or we can get a consultation. And I think you guys, probably the bulk of you, are going to check this one. You have probably met this patient in clinic. This is by far the most evidence-based treatment for most causes of unsteadiness in older adults. So even if you were just playing the odds in Vegas, sending her to physical therapy is the most likely thing to help her. It's absolutely C. Though you're going to address other intrinsic and extrinsic causes, right? Like if she can't see well, she needs her glasses or her cataracts removed. You want to treat her diabetes so her peripheral neuropathy doesn't worsen. You might send out home health to make sure she doesn't have tripping hazards in her home, right? But a strength and training program is by far the most evidence-based way to treat this woman. You do not need neuroimaging or a cardiac workup. Your exam was easily understood, right? All of her exam findings are consistent with the diseases that she has, and her story is perfect for disequilibrium. You understand the story, you understand the exam, you do not need further workup, okay? All right. Other tricks for disequilibrium. Discontinue medications is obviously a big one. I know you all focus on deprescribing, especially in older adults. And we want to attend to all of the other things like hydration status, assistive devices, et cetera. When I asked my geriatrician friend, Dr. Wayne McCormick, to tell me how he approaches disequilibrium, he told me in his very dry way, think about every possible cause and intervene on all that are amenable to change. And that is how you think like a geriatrician, right? I don't know if there are any geriatricians in here, but that is totally it, right? This is why their appointments take so long and they're so effective at what they do. So I think this is a humbling quote, but apt to end this section on dizziness, because it really speaks to why we all chose this specialty of internal medicine, right? Like we don't want to just think about a person in parts. We want to think about the whole first person. And although it takes us a long time, boy, howdy, does it take us a long time. We want to try to help every little bit of them. All right, finally, as promised, we're going to talk about non-specific dizziness, our final bucket category. So this is a typical illness script for non-specific dizziness. This is a person, you can read the script here. I will tell you this clues to non-specific dizziness in this gentleman are that it is non-debilitating. It's untriggered, but the buildup is over minutes, not like a thunderclap onset. And then on his exam, you don't have any cardiac or neurologic findings. So what do you do in this guy? Okay. It's not quite as straightforward as sending that lady to PT because you don't totally have this diagnosis nailed down yet. Because depending on his risk factors, severity of the presentation, and his preferences towards his approach to care, is he a if it ain't broke, don't fix it guy, or is he a better safe than sorry kind of guy? You might consider a workup for arrhythmia or structural heart disease. You are probably not going to need neuroimaging in this patient given that illness script, which fits none of the illness scripts that we mapped to central nervous system disease, okay? But what you are going to need if you land this patient in the bucket of non-specific dizziness is reassurance, deprescribing, and a focus on coping. And I'm going to emphasize once here, again, deprescribing is really important here because so many medicines cause dizziness and withdrawal from so many medicines cause dizziness. For him, I'm particularly worried about his gabapentin causing dizziness. And I'm particularly worried if sometimes he misses his doses of citalopram, which could give him an SSRI withdrawal syndrome, which could cause dizziness. So deprescribe, deprescribe, deprescribe. Focus on coping, do a rational workup that you come upon in conversation with your patient. And then you focus on coping once you have convinced yourself that this is nonspecific. And then it might take you a little while longer to convince him that it's nonspecific, but once you do that, you can focus on coping with this. Please don't add therapies that could cause harm Like, don't give him meclizine, for example. Meclizine is my least favorite medication for the treatment of dizziness because it makes people more dizzy usually, unless they truly, truly, truly have vestibular neuritis. And I don't think you necessarily need to do any extensive workup if you have a good relationship with your patient and you understand their exam and presentation. So if a thorough history and exam is enough to reassure the doctor, I find that then with a good relationship with my patient, it's often enough to reassure the patient. Even just a history and physical is enough. And I think that this is a really good note to end on because I think it comes down to what I find most challenging, but also rewarding about being a primary care, chronic care doctor, which is that patients put a lot of trust in us. And if we build our skills and are confident in our diagnostic skills, and then we can transmit that to our patients and do the right thing for them, then they will feel a lot better whether you make their dizziness go away or not. So take home points here: timing and triggers to narrow your differential. Detailed but targeted exam to determine the need for advanced diagnostics. Consider empiric repositioning for clear-cut BPPV, even if there's no positive Dix-Hallpike, as long as there are no alarm features. If your patient has disequilibrium, then you need to slow down and think like a geriatrician and examine everything and do everything. And then you manage nonspecific dizziness by deprescribing and a focus on coping and reassurance. And I think that there's references here, not too many, but some high yield ones. And I will go ahead and take some questions now. Well, thank you.
Given by the time you get someone up on the table to do the Epley maneuver and you explain what you're doing and their sore knees and all that, excuse me, the Dix-Hallpike, why don't we just skip the Dix-Hallpike and just do the Epley maneuver? That's one question. And then a related question is, am I undoing things or making things worse if I do the Epley maneuver on the wrong side, or can I just do it on both sides if I don't know what's going on?
Those are amazing questions. Number one, okay, I'm going to answer this in 3 parts. Number one, you can do the Dix-Hallpike and Epley repositioning maneuvers in a way that is more comfortable with your patient. You do not need to hang their head off of the exam table. You can prop a pillow underneath their shoulders and do it. I have done this exam in one of those motorized wheelchairs that like goes all the way back and just had the patient turn their head. Okay. So I never have my patient get backwards on the exam table and hang their head back. I just have them lie on the exam table and put a pillow under their shoulders. It only matters, the head position matters. That's it. Why do the Dix-Hallpike and the Epley? Well, that's easy. The Epley, the first 3 steps of the Epley are the Dix-Hallpike maneuver. So no time lost there. And then what was your third question again?
Is it okay to do the Epley on both sides? Am I undoing and making it worse on the other side?
You need to pick your side. Pick the side where the patient is most symptomatic. So I told you need to kind of estimate your side when your patient is giving you the history. That's where you start for your exam. But there's going to be one side that the patient is more symptomatic on when you actually do the maneuver. If not, like bilateral BPPV is extremely rare. So if it's equally positive on both sides, then you need to rethink your diagnosis. And you're going to pick the side, you're going to correct the side that is most symptomatic or provokes the nystagmus. Sure. I think that it theoretically could be. I don't think there's an evidence-based answer to this question. I wish Dr. Epley were here, but I think it theoretically could be, because literally what the Epley maneuver does is try to get the canalith back into the appropriate position in the at the top of the semicircular canal so that it can exit those ducts. And this is why we have patients, after you do the canalith repositioning, we ask them to try to maintain stillness and not move their heads too much for the next 24 hours, because theoretically it could disrupt your exam. So I would not. I would pick your lane and do it. Don't try to do both. You might mess yourself up.
Great. Other questions here specifically in the room? Well, folks are thinking on it. One question emerged. Can you, best you can, give us your illness script for vestibular migraine?
Yeah. So it's a migraine. So I like to combine the migraine illness script with vestibular symptoms. So we're talking about timing and triggers. A migraine, we typically think of a migraine as typically coming along with a headache, but a vestibular migraine often confuses us because it can be acephalalgic. I like to use fancy neurologic words because it makes me feel smart. But that just means it can come on without any headache. So then I would think about timing and triggers, not just qualitative symptoms. So a migraine typically comes on gradually. So maybe over 15 to 30 minutes, builds to peak intensity, typically tends to be pretty debilitating and lasts hours to a day. Okay, it may be triggered sort of more proximally by typical migraine symptoms or typical migraine triggers. So alcohol, certain foods in certain patients, lack of sleep, stress, etc. And then a vestibular migraine is generally not going to be accompanied by any other neurologic features. Typically also in terms of the illness script for who the patient is, we're generally not making migraine diagnoses in older patients with a lot of risk factors, because if you are going to get migraines, you are typically going to get them when you are younger and healthier, that they show up early in your life. Yay. And so I would not be thinking about a vestibular migraine new diagnosis in someone who is older. That said, I think it is completely reasonable for an internist to need help making the diagnosis of vestibular migraine. I've never made that diagnosis all by myself. And I think it's great to have it on your differential, but I think our job is to exclude other dangerous things before we let the neurologist diagnose the vestibular migraine. Does that help?
Great, thank you. Well, we have 4 minutes, so maybe we go for it with
Let's
the
go for it.
demo.
Okay, Dr. Schaefer, can you come? Okay, residents, I need you down here. Have to gather around. Gotta move. I do want you up here. I don't have a pillow, so we're gonna old-fashioned way. Okay. No, you're good. Wacky thing. Okay. This is this wacky thing that I made like many, many years ago out of pipe cleaners, headbands from Bartell, and I found it. So semicircular canal. All three. Obviously, life they're a lot smaller and inside your ear. But that is obviously in real life, it is a tiny little rock, and it is inside the semicircle. Dr. Schaefer here is going to demonstrate posterior canal BP. So could you please? Okay, I don't know. Someone else. Okay, someone else needs to film. Okay. Look, my friends. Posterior canal. Remember, 90% of them. This little otolith is supposed to be in there, snug in there, adhered, not causing any problems. But when it flips back here, it causes some problems. It gets a little hair cells moving, which stimulates the nervous system to think that he's moving. I'm going to have you scoot back just a little. Okay. So remember when I was telling you that the reason we turn 5 degrees right is to bring that semicircular canal into the maximum plane position. Here's why. Alex, I'm going to put my hand if that's okay. I sanitized before we had dinner together last night, so if we're okay. See how now this is in the plane. Have you scoot forward a little bit more? Okay. And then what we're going to do on the count of 3, I'm going to slowly lower. Slowly lower you down, to which your job is to keep your right ear over your right shoulder. End up with your head hanging off of the table, and you are going to feel dizzy. It's going to be okay. Drop on me, it's okay. Okay, so 1. Slow. And if you had less mobility, we could just put we call it a pillow underneath. Okay, great. Okay, so see now this otolith is hanging down here. Okay, this is Dix-Hall pipe. We will have done this twice, but that's also the first. Okay, so what I'm going to have you do now, Alex, is I'm going to turn your head so that below the level of the exam table, left ear over your left shoulder. Okay. And then again, keeping your head below the level of the table and keeping your left ear over left shoulder help you turn onto your left side facing. And every time the nystagmus stops and the dizziness goes away, now, say you're feeling better. You're gonna have to spit up slowly. Oh no. That otolith back into the, okay? So what's happening, if you couldn't see, this is his head. Turn this way, go down. Okay? Go over. Sit up. And it makes that otolith go back where. Now it's going to take a minute to exit that duct. So no, I don't want you to do it on me. Messed up all this very. So as my gift to you is this. You can, I will send you the 3D like file. So if you guys want to print your own, you can. You can take that to clinic, and next time you have a patient with BPPV, practice that.
It's the tiara.
And there's also videos of this in my talk, as well as some references for that. You really have to practice these to make them work. And if you have any trouble troubleshooting them, let me know. But next time you guys are doing a physical exam teaching on dizziness, go ahead and try those out. They're really fun.
Fantastic.
Thank you.
Bravo. Thank you, Dr. Thronson.